Hi everyone, thanks for taking time to view this section on functional assessment sensory, dealing with hearing and vision, and also with sleep and rest. Really, when you look at it, if you haven't figured out already, assessment is the most basic part of nursing care. So assessment of health and functioning, especially with the eyes, the ears, and the amount of sleep an older adult is getting, is certainly an essential part of care because this health and this functioning may affect many different abilities. So assessment of health is really a comprehensive, holistic nursing perspective. It's more than just looking for the things that are wrong. It's also looking for areas for teaching and getting basically a baseline understanding of what's going on with the person, what they know, and perhaps what they need to know. So it's really a complex process there where you're looking at multiple comorbidities, better termed as multimorbidities, and acute issues that are occurring there, and look for signs of illness or adverse medication effect. In the older adult, it sometimes can be difficult to locate that as being the causative factor. And unfortunately, treatment for the older adult tends to be more at the symptoms that they're experiencing rather than looking at the source of the problem. And that's where a good focused assessment by a nurse really comes in. Between medication interactions and cognitive impairments, sometimes it's difficult to really get an accurate report. Plus, there's a lot of myths and misunderstandings, as we've talked about in previous units, that the older adult faces in looking at what's going on with them. So the nursing assessment tool that really works well here is the Fulmer Spices tool. And we've talked about this in an earlier unit about spices for sleep disorders, problems with eating or feeding, incontinence, confusion, evidence of falls, and skin breakdown. So in looking at a functional assessment, it's really defined as the person's ability to fulfill responsibilities and perform self-care tasks. The ability to get ready in the morning, get clothes picked out that are appropriate for the season and that are appropriate for matching, for example. Getting up and getting shaved, teeth brushed in the morning, things like that. And then there's instrumental activities of daily living, IADLs, which are the complex tasks that pretty much are used for getting places, to have some socialization, just daily living and social activities. And the idea is that we need to determine if any assistance is needed either with human interaction or with equipment to really optimize their level of wellness. So when you're assessing the use or potential use of adaptive and assistive devices, there's a couple ways to really be looking at this whole picture, because nurses really do have the responsibility to take the action on this, take the lead, and get the help where it's needed. So the first one that you're seeing there, the actual or potential use of mobility aids, this includes canes, walkers, wheelchairs, and adaptive equipment like elevated toilet seats and grab bars in the room. That's called durable medical equipment, DME, and that's a term you'll hear often in healthcare. And then the others are skilled care, another term that you'll hear frequently. So skilled care is the nursing care, also the PT, OT, and the rehabilitational therapists that are really skilled in fitting the right assistive device to the right need there. Our responsibility as RNs is to be familiar with how to use it and also to make the referral to the right discipline for assisting the patients, and then teaching and reinforcing the use of that equipment, which is the reason why you learn how to use it. We provide skilled nursing care. Other disciplines provide skilled care as well. When you look at function-focused care, it's really the ultimate level of wellness, the goal there, providing function-focused care, formerly called restorative care, but it works to get them to their optimal level again, using evidence-based practice guidelines for geriatric nursing. So that means the importance of comprehensive geriatric assessments. And that's why the Centers for Medicare and Medicaid started the minimum data set, also called the MDS, in long-term care nursing homes. The MDS is used to identify the level of skilled care that's needed for all patients, not just those that are receiving certain types of Medicare, to make sure that the level of funding that's being provided to the unit or to the facility is appropriate for what needs to be done, making sure that they're getting enough money to pay the way for things to be done for the patient to help them get back, hopefully making progress on a regular basis to get back to their normal care, their normal ability to do ADLs and IADLs in the home setting. So with Medicare, the patient needs to demonstrate regular positive progress toward established nursing and therapy goals, or eventually Medicare will deny coverage, and that leaves the cost to the patient for custodial care, what we've talked about in the past, which gets paid out of pocket by the resident for providing day-to-day ordinary care. Different again from skilled nursing care and from skilled therapy type care. Chances are at the facility there would be an MDS coordinator, who's often a nurse, who pulls together all the information from all the disciplines and ensures that the continuity of care and progress are being made and documented. And they'll work together with therapy and with social services and identify the needs, the levels of care, and ultimately maximize the amount of reimbursement available so that they can afford to take care of those patients who maybe cannot afford to pay on their own due to having disabilities or having no money. This really carries over to the home care setting as well then. In the home care setting, after they've been discharged from a rehab type facility, many times there'll be a referral for a home care nurse, or possibly also additionally home care therapy, to assess the safety in the home, the environmental factors that influence the person's safety, functioning, and quality of life. And with that, they're identifying fall risks. Are there throw rugs that are potentially laying around loose that could slip and cause a fall? Are there cords crossing pathways that make safety a little bit of an issue there? Is the lighting decent for being able to see both in the daytime and perhaps good hallway lighting at night, so when the person needs to get up to go to the bathroom, they're not operating in the dark with a walker and trying to maneuver where they can't see? And how is the temperature? Remember, we have to think about thermal regulation, especially with older adults. Now, depending on the funding source, there's significant documentation that could be needed on the home care front, as well as making sure things are tailored toward a demonstrated need and the provision of skilled nursing care or skilled therapy care, or both, and the different levels of reimbursement that take place because of that. Now, driving safety is another concern the nurse should pay attention to. It's an IADL, and it can be a difficult topic to broach, but it should be routinely incorporated into the assessment. Also getting information not just from the patient, but also from the family members, because they might be looking for help in this area, and the older adult maybe isn't the most willing to do that, and they might not be saying anything until it's asked. But there are a lot of psychosocial implications related to driving, stopping driving for the older adult. Their ability to do social things could be diminished there, although there are other options for transportations. Age-related changes to their vision, to their musculoskeletal function, and others can really have an effect. Also, medical conditions, medications that are being used, and even alcohol consumption can be playing into that. And concerns actually apply to night driving and to safely changing lanes. And the interesting part is that a person with dementia, for example, in early dementia is still capable of driving, but there needs to be a way to identify and recognize when that time is changing before any risks happen. And as a result, this is something that the nurse needs to bring up in discussion there, because the family is likely to seek guidance to address safety, so you can give them resources available, driving evaluation programs that help not take away the privileges right away, but ways to improve safety, such as modification of the vehicle or limitations on when they drive, and certain driving education programs that are designed for older adults. In our next section, we're going to head into the discussion of hearing.